Hello, everyone. Namaste. First of all, my sincere thanks to the organizing committee for the opportunity to participate in this webinar, especially to Dr. Bodha Subedi for organizing this important session. Now, let me jump right into the subject of this webinar, reflecting back to our experience of management of cancer patients during COVID. There are multiple things that come to mind, but I guess we can divide our experience overall into two tiers: experience from systems perspective and our personal experience in providing care to our patients. When you talk about systems level, it definitely will be tied to the healthcare system that we work under. Personally, I work in Canada, which is a country of 37 million people, with about 250,000 new cancer diagnoses per year, which contributes to about 85,000 cancer-related deaths annually. We have a universal healthcare system, so diagnosis and treatment of cancer is a responsibility of the state, which is relevant because in countries with such system, there's usually a well-developed framework in terms of cancer control. And whenever we are faced with difficult situations such as the pandemic, we can make changes or adjustments to the healthcare system, relying on the already developed framework, which is what we did during this pandemic. So reflecting back to the beginning of 2020, when the Western world was hit by the pandemic, it really started as denial, to be honest, and that was quickly followed by lots of confusion, lots of chaos. Coming to the specifics of how we dealt with the pandemic here in Canada, first of all, the most important thing is we came up with a prioritization of different cancer services. From low priority service to high priority service, the underlying rationale of prioritization was guided by basically two principles. First, it was intended to minimize the transmission of this virus, which nobody knew about. It could be as lethal as Ebola, it could be as lethal as contagious as smallpox per se, so nobody knew. So the policies were mainly driven by, intended to protect us from the worst case scenario. And secondly, it was guided by our fear of possibly overwhelming our healthcare system, which we formally know as flattening the curve. In terms of direct delivery of service to the patients, I would say that there were a few factors that were considered in assigning priorities. First of all, for a given cancer condition, we considered whether there was alternate treatment that was available, which could be delivered outside of the cancer treatment facility or the hospital, so that unessential hospital visits can be avoided. Secondly, what is the magnitude of expected benefit of a given cancer intervention, so that we could assign a priority based on the value that a particular treatment has to offer to the patients. Thirdly, we also considered whether certain treatment was curative versus palliative, because curative treatments were given a higher priority than palliative treatments. And lastly, it was driven by the nature of the cancer also, because the aggressiveness of the cancer comes into play, whether we have some time to buy before we offer treatment or not. So those were general principles that were used for prioritization. Now, from the systems perspective, we had to put a lot of things into back burner. For example, non-urgent or elective surgeries were put into back burner. Cancer screening, for example, was completely halted in the initial few months, which were later resumed after we got a handle on controlling the infection in the community. Now, what I would really like to highlight today is that this pandemic really served as a rare, once in a century reminder that the most tragic, most chaotic, most disorderly situation also present us with tremendous opportunity to find stability, order, and progress. For example, had it not been for the pandemic, I cannot imagine how many years or decades would it take for us to develop an mRNA vaccine. That has never happened before in the history of medicine. And we've never developed a vaccine with 100% efficacy, close to 100% efficacy to prevent hospitalization and death from a very lethal virus. And let's not forget that it was also developed within a matter of a few months from the start of clinical trials to the approval of vaccine. This situation was really not imaginable even 1 year before the pandemic. The pandemic also brought the whole world in one place. We could observe unprecedented collaborations across the world to finish the clinical trials of the vaccine, of the therapies to COVID-19. The role of international organizations like WHO was further established. They really worked as a really pivotal point to coordinate different programs around the world. And we had the opportunity to distinguish the wheat from the chaff, so to say, with regards to the evidence, the level of evidence that we need to change practice. We all learned it the hard way. We remember the stories of hydroxychloroquine, azithromycin, and whatnot on that regard. But last but not the least, what I would say is that this pandemic was a great opportunity for us all to witness the extreme, unfortunate disparity in access to healthcare around the world. Although we pride ourselves as being in the best time in the history of mankind, which is right, but the pandemic has been a constant reminder of the very regretful inequity between the haves and the have-nots, both within a society but also internationally. For example, wealthy countries like Canada or Western Europe, United States, they're not far from vaccinating almost 100% of their eligible and interested citizens. But back home in global south, including in Nepal, we are still struggling to get the vaccine into the arms of most vulnerable population in the society. I think this is our new enemy, and we need to come together to fight it. I think the single take-home message I have for a forum such as this, the third Nepali Global Health Conference, that we should show solidarity and unity in our common mission to end this shameful disparity between what we call the global north and global south. So I urge all of us in this conference, and many of us are in a position to make changes within Nepal and outside Nepal, to consider this reprehensible inequity in access to even basic and essential health services while formulating long-term health policies. And I think and I believe if we work together, health equity is absolutely achievable, and this should be the single most important priority for us all as global citizens of the 21st century. Thank you very much.